the research purposes. Lower motor neuron losses, which is easier than upper motor neuron loss when we are looking in progression and we are looking for atrophy, weakness, fasciculation. AMG is the cornerstone in the diagnosis of the microarterial sclerosis, and some in the newly revised scorecard criteria and award criteria for diagnosis of amyotrophic lateral sclerosis. The subclinical denervation, even without any symptoms, it can be enough for diagnosis ALS. The additional cardinal feature, the frontotemporal dementia and the cerebral affect, it's a very important role because it's less likely to see these two symptoms in the potential alternative diagnosis. Thank you, sir. It's early morning. And it's Friday. I don't imagine tomorrow. I will present Friday at very early morning. When we assess frontotemporal dementia and the dementia clinic, the 15% of the frontal dementia patient will have ALS. First, in our neuromuscular clinic, when you assess the ALS patient, about 50% of the ALS patient will have behavioral type of the frontotemporal dementia. The patient may come with apathy, lack of the enforcement, fewer rewards, can be assessed as dysarthria, and actually is related to frontotemporal dementia. And when we are assessing patients with ALS, we ask about the family history of the ALS, and I think it's good to emphasize about the asking family history of dementia, and especially frontotemporal dementia. And also the pseudobulbar affect in about 30% of patients of ALS. It's like age of crying and laughing. The good things in frontotemporal dementia and pseudobulbar affect, it's in the potential mimicker is less likely to find both of them. I'm going to talk about the diagnostic criteria for ALS and the World Federation of Neurology in Els Corial. It's actually the Els Corial is the historical Spain residence in the Spain, and it's conference room like this, and in San Lorenzo, 45 kilometers away from the Madrid, the capital city. They start emphasize about the diagnostic criteria of ALS, and they revised it in Virginia, an airline house, and they published in 2001 the revised Els Corial criteria. And our G criteria, which is the third revision, the second revision for the third revision for Els Corial and the small island called Awaji in Japan, and there is some changes from each diagnostic criteria and other. And there are some talk about the fourth revision, which we published hopefully this year. Then the importance for this diagnostic criteria just for codifying features, and it's mainly for research purposes to start some medication, and the cause of them also it's accurate and time of the diagnosis itself. It's as all of us know, there is definite probables, possibles, and this is not implied that when we hear the definite probable, it's thinking about the diagnosis itself. It's not implied that the alternative diagnosis, but the definite, probable, and possible. It's more emphasized about the diagnosis certainty. And the probable, which in the second airline's house, or the first revised Els Corial criteria, which laboratory supported, which changed with time and started being our criteria as enough subclinical denervation is enough for diagnosis of ALS. And in the fourth revision, which we published in this year, They take out the progressive muscular atrophy out from the Awaji criteria, but they're gonna retain it back in the fourth revision of Ellis Correal with flyer arms, diplegic amyotrophy, and progressive bulbar palsy. I'm gonna talk about the electrodiagnostic test, which in the patient, the neck conduction study, usually it's mainly for alternative diagnosis and exclude the other differential. And AMG, and it's very important and have the most valuable role in the diagnosis of amyotrophic lateral sclerosis. And we're going to look for active and chronic denervation, which I will discuss later, and document of subclinical denervation. So sometimes the active denervation will be a start early before the patient starts to be symptomatic and needs about losing of about more than 50% of the motor units before muscle start to be weak. Okay. As we know, the causes of ALS and pathophysiology is unknown for some extent, and as we know, they started by denervation and ongoing denervation, and collateral re-innervation started to appear, and there is immature re-innervation, and as we know, there is ongoing denervation and immature re-innervation. It's persistent in the patient with ALS, and there is unstable motor unit, which will be discussed. Active denervation. In the first Ellis Correal criteria, the fibrillation potential, it was the only active denervation taken in the patient of ALS, but in the revised revision of Ellis Correal and Awaji criteria, they start to include the fasciculation potential as enough sign for active denervation. We will look also for chronic denervation, like either qualitative or quantitative, which discussed by Dr. Sajjad yesterday in the workshop. Increase amplitude, increase durations, increase the number of phases, because the increase of the metals in the motor unit itself. And as we know, it's ended by decreased recruitment secondary to decreased number of units. Fibrillation and positive wave now start to be used frequently. Ultrasound, as it's mentioned by Dr. Bama yesterday, for assessing patients of amyotrophic lateral sclerosis, and it's fairly equal when we are looking for fibrillation and positive wave, in 45% in NG and 31% in muscles. We are looking for when we are looking for fibrillations. And also, as we look at this picture, there is changing in the echogenicity of the muscles because of the chronic denervation. And fasciculation. This is discovered because it was removed at the beginning from the Ellis Correal, the fasciculation, because sometime a non-expert myographer, sometimes the postural motor unit is recorded as false fasciculation potential, as we know, as we look to this view. But when we are looking for the raster mode, it must be the fasciculation potential is not coming as similar to each unit, and we are looking in the raster. In the second image, we are looking, it's different. Each one is different than other, which indicates more fasciculation. And we have to wait for about 60 seconds, and this likely we will find any fasciculation after the 60 seconds. And the other thing which make them remove it from the first Ellis Correal criteria, because the presence of benign fasciculation syndrome, and as we know, it's easy to assess the fasciculation itself, and we can differentiate between the chronic neurogenic picture, which we are looking in the fasciculation, and it helps us to look and emphasize about benign fasciculation potential. Also in the ultrasound, we can detect the fasciculation potential, and it's surprising. Ultrasound is more sensitive than EMG in detection of fasciculation. tried my best to look videos for fasciculation. I couldn't find. In our criteria, as I mentioned, which I emphasized here in the literature, the fasciculation potential and fibrillation potential active denervation is added as a criteria and is enough for diagnosis of patients without any symptoms. If we do any muscles and found this active denervation without any weaknesses, and it's considered this segment or this road, it's important in the patient of the ALS. And as I mentioned, there is definite probable, possible, and they removed from the revised Awaji criteria, they removed the progressive muscular atrophy, which will be retained back in the next one. The motor unit instability, as we know, because the immature collaterals and there is ongoing denervation, and it's helped us in the diagnosis of electrodiagnostic for amyotrophic lateral sclerosis. And when we are triggering the potential here, and we are looking for patient with ALS, we have the similar picture for jitters, which called jiggles in the patient in the EMG settings, and it's helped us. It's not specific in diagnosis of ALS, as we know, it's coming with myasthenia gravis, for example, but it's helped in the diagnosis and clinical context of ALS. Okay, the easier to enforce this Awaji criteria and the subclinical denervation as criteria as help in the Awaji criteria, because it's increased the number of muscle with active denervation. When we are looking for subclinical denervation, increased by about 10% and increased the thickness about 20%. Actually, there is multiple study talking about this different number, but most important study which gave us this number. And the number is shifted to higher grade. What's the importance for this? Because the most of the trials, they will start the medication and the patient in the definite certainty of diagnosis of amyotrophic lateral sclerosis. So they shift the patient easily from probable to definite. There are questioning about the shortening time of diagnosis because some patients ignoring because start focally and delay diagnosis. They are seeking the advice of multiple physician. So the yield of Awaji in the shortening time of diagnosis is not that much significant. This is the fourth ELS Corial revision, which will be published in this year, and they will retain back, as we look in this graphs, it will be retained back the progressive muscular atrophy because the life expectancy is similar to the patient with ALS. Clinical diagnostic approach, clinical index, the age, don't emphasize about the age. You may see patients with 90, 100, more than 80, and have the amyotrophic lateral sclerosis. May we see it in the young patient. I also emphasize about frontotemporal dementia. Examination index of suspicion. We are used to looking for first dorsal interosseous as muscle atrophy and the anterior tibialis in the lower limbs. The clinical split hand syndrome is very significant and helpful in the clinical context of diagnosis, which in the atrophy in tenons and hypotenons. And the good things in this split hand syndrome, usually the atrophy is less likely to be caused by the radiculopathy because the C81 radiculopathy is unlikely. It drops maybe secondary to the weakness, maybe secondary to the spasticity itself. This arteria could be our lower. If there is atrophy in the tongue, it's enough. Sensory and electrodiagnostic approach. Sensory nerve, we can do one single nerve if the patient has, just to rule out the alternative. Motor units, amplitude is asymmetrical when you are comparing from side to side, and they may show the individual nerve stimulation decrements. EMG approach, active denervation, chronic denervation, as I mentioned, and chronic denervation, these look for instability. It's well help in the clinical context of diagnosis. I'm going to move the good part here, non-limb muscles. It's good because it's not be emphasized in radiculopathy, which is the big clinical for the amyotrophic lateral sclerosis. EMG algorithm. Actually, in this study, it's excellent and good study. The Bible studies, it's enrolled about 345 patients with probable diagnosis of ALS, and they are looking about the limbs AMG, and they assess the active and chronic denervation and the limb paraspinal muscle, and they emphasize about two muscles with two separate nerves and overlapping roads. Okay. One.
Please. Could you come forward?
That's it.
Can you finish, please?
Okay. And they yield the muscle in the upper extremity using deltoid, first dorsal interosseous, and the lower extremity rectus femoris or vastus latalis with medial gastrocnemius. And the second steps, we go to the thoracic paraspinal. If it's positive, it's a poor diagnosis. If not, we will go to the other high yield muscles, which you can read it in this Bible study. In summary, as we mentioned, ALS is a unique disease. When you are looking to the ALS as it is, there is not rare true mimickers, and it's clinical diagnosis, and EMG is played an important role in diagnosis of microcollateral sclerosis. If you didn't have insufficient EMG, as you know, give the patient time and return back within 3 to 6 months and repeat the EMG. Thank you so much.
Thank you, Dr. Abdurrahman, for the nice presentation. And sorry, we need these all to be on the time. And the second speaker, which is Dr. Mahmoud Al-Haji, is a consultant neurology and neuromuscular and EMG from King Fahd Hospital in Al-Ghufuf. So welcome, Dr. Mahmoud.
Good morning. Thank you for the kind invitation. I'd like to start my talk with a case. I'd like to keep my session as interactive as possible. I'll ask some questions that might seem to be quite easy, simple, and basic. Please don't be offended. It's meant to be interactive. It's meant to be for refreshment. So I have no disclosure to be made. So I have seen a 53-year-old newly diagnosed diabetic patient who presented with a left wrist drop. It was painless. He couldn't accurately date the onset of the symptoms. He also complained of some sensory symptoms in the left hand. There's no neck pain. There is no weakness elsewhere. There are no bulbar symptoms, no ease of laughter, no ease of crying. And there's no bowel or bladder dysfunction. On examination, the cognitive function, language, cranial nerves are all within normal limits. The motor system, he has some like marked atrophy in the left triceps, the extensor surface of the forearm, the abductor pollicis brevis, FDI, ADM, and he has weakness in the those muscles, ranging from 2 to 5. The sensory examination was normal. The gait was normal. So, first thing first, as a neurologist, when we encounter any patient, we ask ourselves the first question, where is the lesion? So where is the lesion? Anyone from the audience would like to participate? Is it central? Is it peripheral? Zahra? You know Zahra? Zahra is a resident? Peripheral. It's a peripheral lesion. So it's a peripheral lesion. So at which level? I mean, peripheral lesion extends from the motor neuron up to the muscle. down to the muscle. Anybody? Do you want to do something else? شباب أي أحد. So is it at the level of the motor neuron, roots, plexus? What was that? Reflexes. The reflexes was normal. It was quite normal. There is no signs of upper motor neuron whatsoever. So the weakness, he has triceps. This is radial. The extensor surface of the forearm, again radial. But he has also weakness and atrophy in the abductor pollicis brevis. This is median, ADM, FDI, ulnar. So it spans 3 nerves. So is it at the level of the plexus? Maybe, but there are no sensory symptoms. So this is against plexus, because if we localize to the plexus, we would expect some sensory changes, right? Please. Yeah, exactly.
So we focus on the motor needs anterior bone, that's one. And the second thing is it's really a pure motor neural here.
Exactly. So what do you want to do next? Okay. So this is a busy slide. Most of the figures are either normal or mildly abnormal. I would like to highlight the most relevant ones. So there is, if you notice here, the ulnar and radial motor studies, there is quite asymmetry, striking asymmetry between the amplitude of the left side and the right side. So for the ulnar motor response, there is like more than 50% reduction between the left and right side. The left side, remember, is the affected side. Again, the same thing is applied for the radial. No. Of notice, there is the sensory potentials are quite good on the same side. I'm sorry, it doesn't show here, but they are all good on the same side, on the left side. The needle EMG shows active denervation and chronic re-innervation. So as you correctly pointed out, that preservation of sensory potentials kicks us above the level of the dorsal root ganglia. So it is either root or motor neuron disease. And here is his cervical MRI. And this is a video for the axial cuts. Let's say play a video. Try to play the video. Okay. So quite severe degenerative changes at the level of the cervical spine. So now, what do you think? Is it, so what's the differential now? Anybody? Is it cervical radiculoplexus or cervical radiculopathy, polyradiculopathy, or motor neuron disease? Remember, it's painless. Nothing in the lower limb. There is no weakness elsewhere. Zahra, you should not talk because we saw this patient together. Absolutely, Dr. Yeah. There is absolutely no conduction block, no demyelinating lesions. Sorry for that.
Yeah, can you go back?
Absolutely, yes. Okay. I'm having technical difficulties here.
Because I thought on the opposite figure of nerve there, from 5.2 and went down to 0.86 down to 0.48.
No, I think there is a problem with the table. It is 0.54. There is no conduction block. So there is, it is all the same. 0.54 for 0.4. So there's absolutely no conduction block. There is.
What about the other side, the right side, 3.86 at the forearm?
There is there is like technical issues with the table, but there is absolutely no conduction block. The CMAP amplitude was 0.54, and it was the distal one. There is no conduction block, and you know that if it is like below 1 millivolt, we cannot call it a conduction block. It was 0.54, then 0.4 more approximately. So there is no conduction block. No, this is the figures here on the right side are supposed to be on the left, but because of there is a change somewhere. So the figures here on the right sides are supposed to be for the left, not the right. And try to correct this many times, but it keeps shifting from side to side. But it is meant for the left side. So there is absolutely no evidence of conduction block or demyelinating features. Okay. Uh-huh. Exactly, yes. But you remember, if we have like a disc lesion that compress the cord above the lesion, above C5, we'll have like hyperreflexia below the level of the lesion. And we'll come to that later on. So what are the differential other than the Dr. Damaski rightfully pointed out to MMN, but there's no conduction block. The other thing is ALS and cervical polyradiculopathy. The thing against MMN is there's no conduction block. Usually the weakness in MMN follows a single motor nerve, but here we have like a myotomal distribution. And cervical polyradiculopathy and motor neuron disease, the weakness is myotomal. So it spans different myotomes, different nerves. So now, what do you think? Is it MMN, or MND, or polyradiculopathy?
From the EMD, we show there is an active and chronic degeneration, which is very fitting more of the last multi or MD, because we have an active, chronic degeneration. So here, it has significance, however, the bottom, that's clear. But also we need to keep the public maybe follow-up therapy for 6 months.
I couldn't agree more, yeah. So ALS is basically a progressive motor neuron disease with a mixture of upper and lower motor neuron findings. Diagnosis is based, Dr. Abdurrahman has touched on that. The diagnosis is based on meeting the criteria and excluding the possible alternative differential diagnosis.
So the most common presentation of ALS is dysarthria, hand dysfunction, the split hand syndrome, proximal upper limb weakness, foot drop, fasciculations, exercise intolerance, respiratory failure, cognitive impairment. The feature that is in favor of ALS is progression over the time. This is one of the most cardinal features of ALS. Patients with bulbar involvement are unlikely to be misdiagnosed. ALS patients with bulbar involvement are unlikely to be misdiagnosed. So this is the split hand syndrome, or split hand sign. I will not I will not speak about this. Dr. Abdurrahman already spoke about this. So what are the features that argue against ALS? Lack of progression. Patients who never develop bulbar symptoms, early bladder or bowel dysfunction, pain in general is generally quite unusual in early ALS. Prominent sensory symptoms, ophthalmoplegia, dementia, although we have like ALS, frontotemporal dementia spectrum. Symmetric findings, if the patient is present with symmetric findings, usually ALS start focally, and duration greater than 2 years, because we know that the mortality is quite high in the first few years. And young age at onset. The last patient I saw with ALS was like 43. So it's not unusual for a patient to present early on. So this is like a laundry list of ALS differential diagnosis. I will not go into it. The most common differential diagnosis of ALS is cervical spondylosis, MMN, and sorry for that, MMN, kidney disease, and peripheral neuropathy. So for the, how can we differentiate between cervical and polyradiculopathy and ALS? The cervical polyradiculopathy is 3 minutes. Oh, okay. It's usually painful, and it's, I mean, it spans many routes. ALS is again painless, and there is like bulbar symptoms. So differentiating between ALS and cervical myeloneuropathy is sometimes difficult, because cervical myeloneuropathy sometimes affects many routes. If there is a cord compression above the level of the lesion, it could give you upper motor neuron signs in the upper extremity. If there is a disc in the lumbar level, it could give you lower motor neuron symptoms and signs in the lower extremity, so it could mimic ALS. So back to our case, is it ALS or not ALS? We don't know. So if a picture worth 1,000 words, then a video worth probably 1,000,000. So what do you notice here? There is a perioral fasciculation. Okay. So basically, this is Kennedy's disease, one of the mimicker of ALS. I will skip into the, so what's this? So this is an article from The Guardian, The Perils of Being Your Own Doctor. So he's an eminent professor who has experienced some fasciculation, and then he thought he has had ALS. And he went to so many doctors, nobody can convince him that he doesn't have ALS. So the benign fasciculation syndrome is thought of as a syndrome of medical students. This is not true. Even eminent neurologists can be affected by this syndrome. So in a cohort, there are 3 cohorts, Irish, Scottish, Italian, and American cohort of ALS patients. The rate of error in diagnosis of ALS ranging from 8 to 3.9. The American cohort is 3.9. The reduction in the error rate was probably because the patient were, most of the patients were evaluated by a specialized neuromuscular specialist. And what is unique about this cohort is the HSP was more identified than the other cohorts. So the take-home message is ALS is the most common motor neuron disease in adults. Many conditions can mimic ALS. Only time will tell. So our patient, we don't know, is he ALS or not. So we should avoid a premature closure and never completely close the door on a possible alternative diagnosis. Thus, the importance of the follow-up of our patients. Thank you.
Thank you, Dr. Ahmed, for an excellent presentation. Our third speaker is Dr. Shirin Al-Qurashi. She is a woman, she is consultant in neurology and clinical neurophysiology from Cloud Hospital in Morocco Healthcare in Germany. She will talk about active and treatment of anxiotic lateral sclerosis. So please call me to welcome Dr. Shirin.
بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء والمرسلين. I'd like to thank you all, the organizers, specifically Dr. Aisha Sharif and Dr. Kibler for keeping up, for organizing this first wonderful scientific Saudi Neuromuscular Society meeting. And thank you for my preceding speakers for making my talk easy, because I'm going to really concentrate on the treatment of ALS, but we'll just touch base on ALS. So you've heard about ALS being a disease of upper and motor neuron disease, on upper and motor neuron, a cluster of upper and motor neuron signs. So if you really divide the neurospine into bulbar, cervical, thoracic, and lumbosacral segments, should have features that would be present everywhere. You would have neurodegenerative signs, and you will have a lot of signs that are alluded here. And you may have some in the lower motor. Of course, you've heard about the fasciculation, atrophy, muscular hypotonia, cramps. All those signs would be present. Usually ALS spares the sensory symptoms. You may have sensory dysfunction, but you wouldn't have any sensory findings. There is a sparing of the nucleus of Onuf, so that you don't have a lot of bowel bladder dysfunction. You don't have a lot of, you may not have autonomic features and dysfunction, and you wouldn't always have some visual abnormalities, and may have some movement disorders, and cognitive impairments aren't really that consistent. You all heard about the Scorial diagnostic criteria. I'm going to skip into that, but it's a combination of upper and lower motor neuron findings that may be present, and usually would be spreading and progressive in nature when they're present. to fulfill the criteria. And you have to have, different segments be involved to fulfill the diagnostic criteria. And with, of course, as we've heard earlier, that the diagnostic and pathological evidence of other diseases are spared, so you don't have any other alternative diagnosis. And of course, in neuroimaging, you wouldn't be having a lot of abnormalities. You may have some cord abnormalities, but usually they are sparing, and you may have some, the lateral corticospine, you may have some enlightening of the lateral corticospinal tracts. That is the only abnormality that you may find. We've heard a lot and exclusively a little bit on the differential diagnosis, cervical spondylopathies, myelopathies, syringomyelia, bulbia, Chiari malformations, intoxication, metabolic diseases, hyperthyroidism, hyperparathyroidism, hypoglycemia, some deficiency of enzymes like hexaminidase, and paraneoplastic presentation may mimic or may be a differential diagnosis of ALS. A lot of paraproteinemias, and we have, different types of ALS, Parkinson's dementia syndrome type. The SOT mutation variables may have different motor neuron disease presentation. Those are the familial ALSs, viral, bacterial, and vitamin B12 deficiencies. We all know that the workup is basic. You may have a slight increase in CK levels, not much. And of course, you'd have to do some of the basic investigations to rule out the differentials as a part of workup. If you do the CKs, as I said, about 2 to 3 times the norm, not extremely high, and the CSF may show a slight elevation in the protein, usually not exceeding 100 milligrams per deciliter. So, Dr. Abdurrahman Ali has presented about this diagnostic criteria, so I'm going to skip those, but they're present for your references. And of course, the pathology would show specifically the loss of anterior horn cells with sparing of the on-off cells, and you may have some things like hyalinobodies, axonospheroids. These are important for those who are writing their boards to know about them, because these are favorite pathology questions in neuropathology. Okay, I guess from here is more the essence of my talk about the treatment and the prognosis, and what can we do? We all kind of know that ALS is sort of it's one of the deleterious diagnoses that we neurologists face in our clinic. Once you have this diagnosis, I have to take a big sigh, and it makes it easy for me to deliver this diagnosis, because you pretty much know that this patient is going to die, and it becomes extremely hard for you and for the patient to receive this diagnosis. The prognosis, usually if untreated, 50% may be dead by 3 years, 20% may live up to 5 years, and 10% may live for 10 years. Usually those who have the bulbar onset are worse prognosis. Familial ALS with specific SOT1 mutations are worse prognosis. If they had a progressive arm and leg or simultaneous involvement, may have worse prognosis. And of course, older age would have worse prognosis. Males probably have a little bit better, not consistently. I'm going to tell you about a case that I faced, and probably the reason I'm presenting this because it's one of the recent cases, and after approval of a certain treatment that I'll allude to, it was the first patient that we started him on specific medications. So my patient, Mr. Abdullah, is a 59-year-old male who in late 2017 presented with progressive bulbar symptoms. He had nasal speech, he had repeated choking, and no weakness except in the small muscles of the hand. His exam, one of the features, I guess everybody who's been in the field long enough knows that ALS kind of, tackles those who are good people, nice people. There's this nice person sign. And so was Mr. Abdullah. He was one of those nicest people whose family members would tell you he is one of the best family members who is always nice to everybody. So nice, polite man. His exam, there wasn't anything specifically positive in his cranial nerves. His extraocular muscles were full. He had, he had normal pursuit. He had only positive tongue fasciculation and positive jaw jerk, hyperactive gag, and he had fasciculations, sorry for misspelling, fasciculations in the paraspinal muscle. The strength in the upper and lower extremities were about 4 out of 5 proximally and distally, with evidence of hyperreflexia. He had more atrophy in the small muscles of hands and FDI atrophy. His electrodiagnostic tests which showed normal nerve conduction studies, and his needle examination was the one that showed widespread fasciculation and fibrillation potential. So this is what we had. You could see that he had involvement of the bulbar, so he had fasciculations and fibrillation potentials in his masseters. He had them in his thoracic paraspinals. He had them in his cervical, muscles, in the biceps, in the deltoid biceps and first dorsal interossei, and also he had them in his quads in vastus medialis and gastric medialis. So my report was really quite consistent with the motor neuron disease diagnosis with this widespread findings, and pretty much fulfilling the scorer criteria. So he wasn't a very big diagnostic dilemma. We knew that he's going to progress, so he was started on riluzole, 50 milligram twice a day dose, and over 6 months he has progressed, mainly became anarthric. He was choking and he had more bulbar symptoms. So pretty much around a year from today, he has progressed, and he was admitted with desaturation, was intubated and ventilated. He had a bout of pneumonia, and initial ventilatory settings were SIMV assisted control with FiO2 of 30%. So looking at what I could have offered to him, he had a progression. I knew that he would have a progression of disease, and we know with the riluzole, with the life expectancy of 3 years, 90% would die within 5 years, especially that he had more of a bulbar onset of ALS. So far until before, riluzole has been the only FDA-approved medication that could be given and had the class 1 evidence for that. You all know riluzole is one of those medications that it is NMD receptor antagonist, or glutamate. It inhibits the glutamate excitotoxicity. And we do not know exactly how it works, because we do not know exactly what is the pathophysiology of ALS, but there has been double-blinded placebo-controlled trials done in the past, which has led to the approval of riluzole. And they usually showed that those who were given a total of 100 milligrams of riluzole a day compared with the controlled had significantly higher survival. So just prolong the duration of the survival by 3 to 5 months did not cure and did not really change much in the survival. For patients, for the subset of the patients with the bulbar onset ALS, there was a greater advantage for survival at 12 months emerged for riluzole group, 73% versus the placebo of 35%. So riluzole has been since then the only approved FDA treatment, and pretty much the thing that you offer all of your patients once you have been through all the diagnoses. You tell them, well, this is the only thing I can give you. Take these pills twice a day and pretty much wait on what can happen. It has been approved, of course, for definite or probably less fulfilling L-scoria criteria, where you have had excluded all the other causes and the symptoms, and usually early on in ALS, symptoms less than 5 years, and those who've had vital capacity of more than 60% of the predicted, and they weren't tricked yet. In 2017, FDA has approved another treatment, Radicava Idarovin, which became the second FDA-approved treatment. So let's go into what has happened. What is the story of Radicava or Idarovin? Idarovin is what, it kind of kind of pushed itself into the approval. I mean, I may just say, initially there was a phase 3 study which looked at its benefits. It kind of failed initially, unless you look at. There wasn't any significant difference in patients who received edaravine versus those who didn't receive it. But when they looked, had another hoc analysis, post-hoc analysis, they found that the patients who had really functional ALS standards that were not as high and early on in the treatment would benefit from Radicava. So, I mean, I highlighted that initially, if you look at edaravine, it didn't show any significant difference in the revised ALS functional rating scale compared to the placebo. But if we look again, where's the pointer? If you look again, those who were aged, of course, the relatively younger patients, you aren't taking older than 75 years, and those who've had, again, forced vital capacity of 80%, and who have been less than 3 years into the disease, they were randomized into either placebo or receiving edaravine. So let's look at what was the study. The baseline characteristics of both arms were pretty much same, with no sex differences. The mean age of onset was 60, and you've had usually patients who had less severe ALS grade 1 and 2 in both arms, and you've had all sorts of patients with ALS with bulbar onset symptoms and with limb involvement. And those who had also ALS revised functional score who was not very high. So what is it? So this is an free radical scavenger, or a novel antioxidant that was initially approved for stroke in Japan, and then it has been, so it wasn't a medication that specifically was manufactured or studied for only ALS patient. When they looked, they think probably it would work, onto dying cells. So they randomized it for 24 weeks, with 24 weeks of open label continuation of the treatment. Usually you give Radicava at 60 milligram intravenously for initially the induction cycle is for 14 days on and 14 days off. And then the maintenance cycles are 10 days on and then 21 days off. And these are for the patients who would be fulfilling the early criteria of ALS. Now there has been, 2 studies. There was the Japanese one, and then it was, FDA has approved it when they had the post-hoc analysis, and another, looking, they took the similar subset and reproduced the same study. And if you're looking at the Japanese study, the ALS severity grade was 1, 2, 3. 2, 3, and with the FVCs of at least 80%. The disease duration was less than 2 years, and you've had at least 2 points for each subdomain of ALS functional score. There was a reduction about 1 to 4 points in the duration of 12 weeks. So this is from my patient's EPIC chart. Come back, EPIC 3 minutes, okay. And this is how I gave my patient, and this is the evidence. So you see the statistically significant evidence was after the primary endpoint. You should look at this study. And after its approval, it was, given, and I'll tell you a little bit about my patient after this is like 10 months or at least now 11 and 12 months. Within being treatment, he's still ambulatory, he's functioning independently. Yes, he is on ventilator setting, but his FiO2 requirement has decreased. It's not his cured, but his quality of life is, hopefully we can send him home on home oxygen. So that's the story of Radicava, and this is the evolutionary thing that has happened since 2017. There is a lot going on into the experimental therapy, the gene therapies, neurotrophic factors, antioxidants, the heat shock proteins. These are still not approved, and usually would be helping in the subset population of familial ALS, those who would have SOD1 mutations. Now, there is no treatment. I'm going to say a word on this. Don't treat ALS patients in silo. It has to be a big multidisciplinary approach. Yourself, your hospitalist, your respiratory therapist, your physiotherapist, occupational therapist, nutritionist, everybody, nursing, everybody has a pivotal role in the management of ALS because it is a multi and interdisciplinary approach that makes a better treatment of ALS. Have an advanced directive, have a talk about what is the patient's will about do not resuscitate, what is their will and what type of comfort measures they want. I mean, I knew many years ago, I diagnosed a 62-year-old American person who really wanted to go home and die, and this is what has happened to him. So. And a word on the symptomatic management. Think about all the other symptoms that happen with patients with motor neuron disease, how to treat all those things so it's not just the motor weakness. All these things would come with it, urea. A lot of salivation gives some of the symptomatic management. I actually like glycoparlowate. It's been very helpful. Emotional lability. We heard about, pseudobulbar effect. Give them the medications, amitriptyline, SSRIs, those would be important. Spasticity, if they develop it, baclofen, tizanidine. Give them all the support through your physiotherapy people. They're the best to guide you into what is best for them. And of course, the management of the respiratory muscle weakness, consider the normal pressure, the NNPPV, which is non-invasive pressure, positive pressure ventilator, ventilation management support if they have developed orthopnea or if they have a significant reduction in their FVCs or if their MIPS, mean inspiratory pressure, is less than 60. These are very important comfort measures that we should be taking. This is an algorithm. It's more for respiratory therapists. And last but not least, don't forget about their nutritional support because you want to know when to peg them. You want to decrease the risk of aspiration and choking and of course improve their comfort levels. Palliative care always. Thank you very much.
There is a shift in the last presentation will be now. Dr. Abdullah will present, and next Dr. SANEM. So Dr. Abdullah Al-Mahdi is a neurology and neuromuscular EEG consultant from Al-Jabra Hospital and Basman Diabetic Institute from Al-Kuwait will give us his experience in diabetic neuropathy. Welcome to the
Okay, Assalamu alaikum. صباحكم الله بالخير. Thank you for inviting me to this great conference. Speaking about neuropathy and diabetic neuropathy in 20 minutes. Type 1 affects children and adolescents, and type 2 affects adults. Screening for diabetic neuropathy starts 5 years after the diagnosis of type 1 diabetes, then annually. In type 2, the screening starts at the time of diagnosis, then annually. Neuromuscular physician needs to know about the diagnostic criteria for diabetes, impaired glucose tolerance test, and impaired fasting glucose for the workup of neuropathy, especially in pre-diabetes and metabolic syndrome. Diabetic neuropathy is probably the most common complication of diabetes. Studies suggest that up to 50% of people with diabetes are affected to some degree. Major risk factors for diabetic neuropathy are the level and the duration of elevated blood glucose. Neuropathy can lead to sensory loss and damage to limbs, maybe amputation. Diabetic neuropathy is a generic term defined as the presence of symptoms and signs of peripheral nerve dysfunction in individuals with diabetes after the exclusion of other causes. Okay, so back to basics. How do we diagnose neuropathy? We have these considerations: which fibers are involved, large fibers, small fibers, autonomic fibers, the structures, the function, the dysfunction, the history taken, the clinical examination of each, pattern of involvement, and the diagnostic findings. This is a sensory axon. To the left side, the heavily myelinated large axons, and to the right side, the thinly unmyelinated fibers or axons. The functions of A, alpha, and beta are pressure, vibration, and proprioception sensations. The A delta and C fibers, pain and temperature sensations. When there are symptoms of involvement of A delta and beta fibers, there is numbness, tingling, or poor balance. When there is involvement of A delta and C fibers, the patient will have pain of different qualities, either burning, electric shocks, or stabbing pains. On clinical examination, the signs we elicit when there is involvement of A delta or beta fibers: anchor reflexes will be reduced or absent, vibration and perception is reduced or absent, 10 grams monofilament sensation is reduced or absent, and proprioception is reduced or absent. While in thinly myelinated or unmyelinated fibers, the thermal discrimination is reduced or absent, and pinprick sensation is reduced or absent. When there is autonomic involvement, the cardiovascular autonomic neuropathy, patients may present with any of these features: resting tachycardia, abnormal blood pressure regulation, orthostatic hypotension, orthostatic tachycardia or bradycardia, and chronotropic incompetence and or exercise intolerance, gastrointestinal involvement, gastroparesis, esophagus dysfunction, diabetic diarrhea, and or constipation. Urogenital autonomic neuropathy may cause bladder dysfunction, male sexual dysfunction, female sexual dysfunction. The patient may get abnormal sweating, like anhydrosis or gustatory sweating. This is the typical distal symmetric length-dependent chronic polyneuropathy associated with diabetes. Starts at the toes, involving small fibers, then large fibers, and maybe autonomic involvement. As the time progresses, there is a more proximal creeping of the involvement. When it reaches the knee levels, then it involves the fingers and hands. When it's very advanced, severe, and chronic, it may involve distal motor fibers. So there are different classifications for diabetic neuropathies. This classification is from Diabetes Care from 2017, a publication of the American Diabetes Association by a panel of international experts in peripheral nerve and diabetic neuropathy. So the diabetic neuropathies, there are the diffuse neuropathy, mononeuropathy, mononeuropathy multiplex, which is considered as atypical neuropathy, atypical diabetic neuropathy, radiculopathy or polyradiculopathy, which is again considered atypical, and on the other side, we'll come to this later. So the mononeuropathy multiplex includes isolated cranial or peripheral neuropathy and mononeuropathy multiplex. The radiculopathy or polyradiculopathy includes diabetic amyotrophy and or thoracic radiculopathy. Then the other group of neuropathies are the non-diabetic neuropathies common in diabetes, which includes pressure pulses, CIDP, radiculoplexus neuropathy, acute painful small fiber neuropathy, and treatment-induced. The atypical features that warrant referral to neurologists or neuromuscular specialists include motor greater than sensory neuropathy, asymmetry of symptoms and signs, and rapid progression. Neuromuscular physician needs to know the differential diagnosis and workup for all the kinds of patterns with involvement, and their differential diagnosis, like any neuropathy, includes metabolic disease, systemic disease, infectious, inflammatory, nutritional, drugs, metals, industrial agents, and hereditary. Distal, symmetric polyneuropathy and autonomic neuropathy are the most common forms encountered in practice. The strongest available evidence regarding treatment pertains to these two forms. Now moving to CIDP and diabetes mellitus. Why CIDP in particular? Because it's potentially treatable. CIDP is a heterogeneous entity caused by an immune-mediated inflammatory process that involves nerve roots, plexuses, and peripheral nerve trunks. The two major criteria are the European Federation of Neurological Societies and Peripheral Nerve Society criteria, published in 2010, and the American Academic Criteria from 1991. So the European criteria have sensitivity of 37.2%, specificity of 90.8%, positive predictive value of 97%, and negative predictive value of 92%. While the AN criteria have sensitivity of 3.6% and specificity of 100%. There will be a dedicated session on CIDP, so I will not go into the details of the criteria. I'll leave it to the speakers. So the association between diabetes mellitus and CIDP is acknowledged and debated. And the epidemiological data of the association between CIDP and diabetes mellitus are in favor of association or no association. In the coming slides, I will show summary of the data in favor of association, then that negate association. A retrospective study from USA published in the year 2000, there were, of 87 patients with CIDP, 30 had diabetes mellitus. A study from France, a prospective study published in 2002, 100 consecutive patients with diabetes mellitus and neuropathy, 9 patients had CIDP. A prospective study published in the year 2000 from USA with referral bias as a potential confounding factor. Their findings are interesting. Risk of CIDP in patients with diabetes mellitus was 11-fold higher than in those without diabetes mellitus. The frequency of CIDP was the same in both types. The odds of an individual with CIDP having diabetes were more than 20-fold higher than in those with myasthenia gravis or ALS. But again, there is a referral bias as a confounding factor in this study. A prospective study from the UK published in the year 2000, 7 of 46 patients with CIDP had diabetes mellitus, about 15%. Probably the next study is the most recent one, published in the year 2016 from USA, in a huge number of patients, retrospective study. They did analysis of health insurance database over 100 million patients across USA. They found a 9-fold increased risk of CIDP in patients with diabetes. This table shows the studies that negate the association. A retrospective study from Italy on a big population of about 4.3 million, among 155 patients with CIDP, only 9% had diabetes mellitus, equating to a standardized morbidity ratio of only 1 for diabetes and CIDP, which is not significant. A retrospective study from USA published in year 2009, I quoted their findings: diabetes mellitus is unlikely to be a major risk covariate for CIDP, but we cannot exclude a small effect. Issues with the epidemiological studies on association of CIDP and diabetes. There is the variation among the population studied, coexisting symptoms and signs of diabetic neuropathies, possibility of overcall or overlook the diagnosis of CIDP depending on the interpretation of the electrodiagnostic data. A dedicated study was published in year 2015. This study came up with diagnostic criteria for CIDP in patients with diabetes based on clinical, electrophysiological, and ancillary testing with parameters, and they gave scoring for each parameter. So they included 27 patients with diabetes mellitus, 18 patients with CIDP, 12 patients with diabetes mellitus and CIDP. Their clinical criteria, they had progressive or relapsing motor weakness for 2 to 6 months with +3 score, significant proximal motor weakness, +3 score, significant upper limb involvement, either symmetric or asymmetric, again, +3 score. Then the last one, the recent onset of diabetes relatively well controlled, is +1 score. The other parameters, the electrophysiological parameter, you see this is very busy table. Basically, this table talks about the parameters, the acquired demyelinating features, like increased temporal dispersion, slowing of conduction velocity, partial conduction block or complete conduction block, and with solid findings of acquired demyelination having more score than the others. The ancillary studies, CSF protein elevated twice or more than the upper limit of normal got +2 score, and if there are associated serological biomarkers, they take +1 score. So they came up with the criteria. Definite criteria, if the patient scores 11 points, if the patient scores between 5 and 10 points, the CIDP in patients with diabetes is probable. If the patient scores between 2 to 4 points, it's the CIDP in patients with diabetes is possible, and if it's below 2 points, it's unlikely. Now, about diabetic amyotrophy. Diabetic amyotrophy is also called Bruns-Garland syndrome, diabetic mononeuritis multiplex, diabetic polyradiculopathy, diabetic lumbosacral radiculoplexus neuropathy. So having all these names means this is some kind of debate and disagreement in the literature about different diagnostic criteria and the pathogenicity of this disorder. But this is either if it's diabetic or non-diabetic radiculoplexus neuropathy, it's due to ischemia and inflammatory vessel disease. So to understand this condition, we go back to our basics again. This is anatomy slide of lumbosacral plexus. In very simple terms, lumbosacral plexus is divided into the upper lumbar plexus, formed by the anterior rami from the motor roots L1 to L4, and the lower lumbosacral plexus, formed from roots L5 to S3, joined together by the lumbosacral trunk, which is formed by the L5 with a branch from the L4. This is lumbosacral trunk. Okay, sure. So the patients present with severe acute pain, either in the thigh, in the buttock, or in the hips, with weight loss, autonomic neuropathy, their sensory loss. If it's involving the lumbar plexus, this is the kind of sensory loss to your left side. And if it involves the lumbosacral plexus, there is the involvement of the other to the right side. In real practice, we see patients having lumbosacral plexopathy on top of polyneuropathy, so you will not have the clear demarcation. So the patient will, if it's lumbar plexopathy, the patient will have in red, the red dots, hip flexion weakness, quadriceps weakness, and hip adduction weakness, and maybe wasting. The ankle reflexes are hypoactive or lost. If it's the lumbosacral plexopathy, the blue dots, the patient will have hip abduction weakness, ankle dorsiflexion weakness, and hamstrings weakness with absent or hyporeflexic ankle jerk. And the lumbosacral plexopathy does not only involve the plexus itself, it goes proximally to involve the nerve roots, distally to the peripheral nerves, and to the contralateral side. There are the clinical variants and associations, which are by some lumped together as spectrum of diabetic radicular plexus neuropathies. The first one is painless diabetic motor neuropathy. The patient will get symmetric weakness affecting the lower and upper limbs, even mistaken as CIDP, called by some people as diabetic CIDP. Nerve pathology shows the same changes in diabetic amyotrophy. The other variant is diabetic cervical radicular plexus neuropathy, which shares many of the clinical and pathological features of diabetic amyotrophy. And the third variant is thoracoabdominal neuropathy in isolation or in association with diabetic amyotrophy. Differential diagnosis. So the big categories are any pathology in the lumbar and sacral roots, or pelvic pathology involving the lumbosacral roots, any iatrogenic procedure, vasculitis or connective tissue disease, sarcoidosis, infections like HIV, amyloidosis, and carcinomatous meningitis. The workup includes the blood work, like hemoglobin A1C, basic blood work, depending on your differential diagnosis, MRI scan for the lumbosacral spine, MRI or CT pelvis, and electrodiagnosis. Lastly, I will talk about the electrodiagnosis. For diagnosis of plexus lesion, we need abnormality in at least 2 different peripheral nerves in at least 2 different nerve roots. Again, this is the anatomy of the lumbosacral plexus. There's the upper one is the lumbar plexus, and the lower one is the sacral plexus. So we design our electrodiagnostic studies. We look for evidence of axonal loss, like low SNAP or CMAP amplitudes with mild slowing of conduction velocity and neurogenic changes on needle EMG. So SNAPs, if we do for the lumbar plexus, technically difficult studies like lateral femoral cutaneous nerve and saphenous branch of the femoral nerve. In the lumbosacral plexus, we can do superficial peroneal nerve and sural nerve. CMAPs, we can do the femoral from the quadriceps, the EDB and TA from the peroneal nerve, and abductor hallucis from the tibial nerve. F-waves, just two more slides of waves from the common peroneal, from the peroneal and from the tibial nerve. The H reflex from the tibial, and probably the EMG is where the money is, like patient with diabetic neuropathy. On top of that, the patient has radiculoplexus neuropathy, so maybe a nerve conduction study will not be very helpful. So we go for needing sampling, looking for evidence of not just plexus involvement, either distally in the nerve roots or more proximally at the paraspinal levels. Management is pain control, physiotherapy, and maintaining good glycemic control. So in conclusion, many forms of diabetic neuropathy have been described. Neuromuscular physician plays an important role in management of patients with diabetic neuropathy. Neuromuscular physician needs to know the different patterns of diabetic neuropathy, their differential diagnosis, workup, and management. Coexistence of CIDP in patients with diabetic neuropathy needs careful assessment. Suspect diabetic hypertrophy in patient if there is asymmetric progressive weakness in the lower limbs with pain at onset. Thank you for listening.
Thank you, Mr. Abdullah, for your nice presentation. We'll keep discussion at the end of the session. Our last speaker in our session is Dr. SANEM. He is a professor of neurology and adult pediatric neurology consultant from Alexandria University. He will talk about gene therapy in neuromuscular disorders. Welcome, Dr. SANEM.
Thank you, Mr. Speaker. صباح الخير وشكرا على الدعوة الكريمة من المؤتمر. أنا لسه واصل الفجر من ساعتين ثلاثة، كان عندي مؤتمر امبارح. الله يسلمكم وشاكر جدا. فاعذروني كنت هبقى مرهق شوية أو حاجة. إنما أنا سعيد جدا إن أنا في جدة باك أجين تو جدة يعني. شكرا. I think the recent things now is talking, in most of the thesis is talking about gene therapy, and we have a breakthrough in neuromuscular disorders, and I know from Dr. Aisha that we have other speakers talking in depth about these diseases, so I will try to cover it in a general rather than in depth in the diseases in this short time. Gene therapy is introducing the nucleic acids into the patients as a drug to change the genetic informations. And it's a way to fix the genetic problem at its source. The polymer that you're going to introduce into the cell of the patients either translate into a protein, or it will interfere with the target protein expression, or possibly correct the gene mutations. The polymer that you're gonna send to the nucleus has to be carried with something, we call it the vector. We're gonna talk about this very soon. We have three modalities in gene therapy, either antisense therapy, or gene targeting, or the gene replacement, or gene editing. So we're gonna do either of three things, and we need to understand it because most of the talks in the sessions will talk about these modalities. The antisense therapy, targeting the messenger RNA, or we are targeting the gene itself by editing or by replacement. The antisense therapy, we are dealing with the messenger RNA. We're introducing what's called oligonucleotides in a sequence opposite to the sequence present. That's the sense, so it will be called an antisense sequence, like this graph. I don't have a pointer. There is no? Okay. In antisense therapy in general, either we gonna inactivate the gene. I'll try to use the, yes, it's okay, sorry. So this is the DNA will send the information outside the cell with messenger RNA. This is the messenger RNA with the ribosome going through the messenger RNA should produce a protein. If I'm sending an oligonucleotide opposite to the messenger RNA, what's called antisense, it will prevent the reading of the messenger RNA to produce the protein. So I will shut off this process and no protein will be produced. This is one technique. The other technique that I will send the oligonucleotide to introduce or target the splicing place in the, or modify the axon in the messenger RNA to let it to produce a better protein or a correct protein. So either I will shut off the messenger RNA, no more protein coming, or I will modify the messenger RNA by introducing or correcting the exon, and it will produce a correct protein. The other technique is to target the gene itself, not the messenger RNA, and to target the gene. We have three Nobel Prize gainers together in 2007 who gained the prize for developing this gene editing. And to edit the gene, you need to reach the specific site of the gene on the DNA, and to do that, you need what's called molecular scissoring. You need to go to the specific site, cut this place, and you work after cutting the DNA. And this what's called molecular scissoring. They have different types, and what you're gonna hear in the next sessions, you will hear a lot about what's called CRISPR-Cas system. After cutting, either you're gonna repair the cut by a homologous technique or non-homologous technique. And this is the CRISPR technique. This is a bacterial defense mechanism, natural defense mechanism of the bacteria, the acquired immunity of the bacteria. This is the CRISPR system, and this in the diagram, we show that this is the virus coming inside the cell. The CRISPR system, the Cas system will identify the genetic material of the virus and will introduce the part of the virus or the message, or the part can identify the virus in its CRISPR array. And this next, if they have the viral again, it will identify the viral directly and will cut it at its specific sites. Somehow, the scientists use this technique, develop it, and instead of using the viral genetic material, will put in the array the proper information that will target that proper place in the gene, the DNA in the patient. And these two scientists were nominated in the human in 2014 in Cell, and I think they are waiting for the Nobel Prize to gain because they have a breakthrough technique in helping the gene therapy. Gene therapy in general can target the somatic cell, so I'm dealing with this patient only, or if you are targeting its germline, I'm dealing with his offsprings. Okay, now the information will be carried on a vector, as I told you, and this vector either viral or non-viral. I'm running because I know it's a very short time. Viral vectors have advantage and disadvantage, and non-viral vectors have advantage and disadvantage. The viral vectors have the advantage of it's naturally have the capability to go to the cell and use the cell machinery to reproduce its genetic materials. And some of them can go further step and have its genetic material encoded inside the DNA will code it encoding capabilities. So the viral vectors, especially the retrovirus, have what's called encoding capabilities. So, or integrating capabilities. This is a very important slide to understand the difficulty in doing the gene therapy. This is the types of the vectors, and I like you to look at what's called the packaging capacity. So each one of these modality has a different carrying capacity. We'll talk it, we're gonna mention it later in the non-viral vectors. We can produce it on a large scale, low host immunity, disadvantage, lower transfection. They don't have this introducing capability except with the sleeping beauty. Most of them, they don't have the introducing capability apart from the sleeping beauty, which is a natural transposon system that have the ability, we call it jumping genome. They can have the capability of introducing itself inside the DNA, and it's not a viral vector. Okay, now we have the three techniques, and we know the vectors. And we have two diseases, the Duchenne muscle dystrophy and the spinal muscle dystrophies. In the Duchenne muscle dystrophy, the gene mutation in the chromosome 21, X-linked as you all know, and it's one of the largest human protein. That's another problem we're gonna mention why it's problem in gene therapy. It's very large protein, and the defects, the common defects will be either deletion in exon 6, either a deletion in the exons or duplication of the exons, or mutation in the exon, or a mutation in the intron. I have two spots, two hot spots, sites from 45 to 55 and sites from 2 to 10. Now, coming to the 6 papers that they awarded the attention of the science in 2017. Now we are talking about gene therapy in Duchenne muscle dystrophy. We'll start with the first technique, gene editing. So now I will go to the dystrophin gene. I'm trying to fix the problem in the gene. And to do that, to go to the specific sites, we need this targeting technique. We call it the CRISPR technique. That's why I'm using the CRISPR mediated genome editing to restore the dystrophin gene expression function. It was an animal study in mice. The beauty of this technique that you leave the gene in its place and you try to editing in its place, so you are not bothered with the size of the gene. You leave it in its place and just try to fix the problem. The problem in this, I mentioned the genetics abnormalities in Duchenne muscle dystrophy is variable. So you design a specific array, CRISPR array, to a specific mutation. You cannot apply it to all the patients. You know, you have to diagnose the patient as a Duchenne, then you diagnose its genetic abnormality, then you start to design a specific CRISPR array to these specific mutations. Another animal study. Then the antisense, most of the drugs that approved are antisense techniques. We are dealing with the product of the gene, the messenger RNA. Now, this antisense technique will use what's called exon-skipping technology. The exon that have the mutation will gonna skip it in the translation to a protein, and what the end result will be a proper protein or functioning protein. The atallurine in patients with nonsense mutation in Duchenne muscle dystrophy, it was a multicentral, randomized, double-blind, placebo-controlled phase 3 trials in Lancet. They collected patients from 7 to 16 years of age with nonsense mutations. They choose patient with 6 minutes walk distance 150 meters or more. يعني ايه الكلام ده؟ هم بيقيسوا ال power of the patients, the ability of the patients ان هم يديله 6 minutes and they let him walk. And they measure the distance he can reach in 6 minutes. This is the standard? Okay. I cannot go into more details. I think you will have other lectures about these subjects. Anyway, atallurine was generally tolerated, and most treatment side effects was not that severe. The problem that the patients did not that generally improves, except the very small number of patients who have the distance between 300 and 400. Now, to replace the gene, it's a very large gene, it's impossible. No cargo can carry that. I will show you the slide, the vector capacity. No vector can carry the whole dystrophin gene. Then one scientist, very genius, he came with the idea, we have the Becker muscle dystrophy with some changes, so we can skip some of the translation. We have a smaller protein, but it's still functioning. So they designed what is called a micro dystrophin. It's like from the from the mobile going to the small, very small one, and it's still functioning. And they designed this study also in animals. They used the standard golden retriever muscle dystrophy models, and they have success in this technique. Spinal muscle dystrophy, spinal muscle atrophy, we have the problem in chromosome 5. The abnormality in the survival motor neurons, we have 2 genes, survival motor neuron 1 and 2, and they produce the survival motor neuron protein. Without this protein, all the motor neuron will degenerate, and in these patients, they have problems in the survival motor neuron 1, and they use the protein that produces with the survival motor neuron 2, and the problem with the survival motor neuron 2 that it's the production of protein due to the lacking of encoding 7 is lower, so they depend on the number of survival motor neuron 2 they have to have some functions. So either I will target the survival motor neuron 2 by antisense therapy to enhance the production of the encoding 7, or I'll go to the gene 1, survival motor neuron, by the gene editing. And this is what we have. The antisense drug approved means it's antisense techniques, oligonucleotides. The target is to increase the exon 7 in survival motor neuron gene. And we have gene replacement by single dose to replace the gene that this case will be cervical motor neuron number 1, okay? And we have another breakthrough in this, and I think by this I will conclude my session. Thank you.